Welcome to the Deep Dive, your shortcut to really getting informed without drowning in data. Today, we're taking a deep dive into some pretty critical respiratory conditions. We're exploring these hidden battles our lungs sometimes face. Our mission, well, it's to unpack the complexities of things like acute respiratory distress syndrome, the details around sleep apnea, and this often linked issue, obesity hypoventilation syndrome. We're going to arm you with some maybe surprising insights into what they are, how they often show up quietly, and importantly, how they're managed. Get ready to understand the incredibly delicate mechanics of breathing and what happens when that vital process goes wrong.
Yeah, and what's really fascinating here is how things that seem totally separate, different issues can actually be, deeply connected inside the body. As we go through each one, we'll look at what makes them unique, sure, but also highlight that delicate balance in our pulmonary system, how disruptions in one spot can ripple out.
All right, let's unpack this with the big one first. Acute respiratory distress syndrome, ARDS. So at its heart, what is it? It's a severe, really sudden kind of lung injury. Imagine your lungs have millions of these tiny air sacs, right? Alveoli, that's where oxygen gets into your blood. Well, in ARDS, these sacs get badly inflamed, damaged. Our sources describe it as this widespread inflammation. It comes on fast, severe shortness of breath. And this thing called refractory hypoxemia, basically oxygen levels get dangerously low and adding more oxygen doesn't help much. Plus, you see fluid buildup on lung scans. It leads to, serious respiratory failure. This is key. It's not just heart failure or too much fluid overall. It's more like the body's own inflammatory response kind of turning on the lungs.
Exactly. And looking at the bigger picture, ARDS is often seen in patients who are already extremely vulnerable, critically ill patients. The research points pretty consistently to severe infections like pneumonia and sepsis as the main culprits. They account for a huge chunk of cases. Sepsis is probably the most frequent trigger, actually. But, it's not just infections. Severe trauma, pancreatitis, accidentally breathing in stomach contents, even near drowning, those can all kick off ARDS too.
Okay, so what does it actually look like for someone going through it? Physically, you'd see someone really struggling to breathe, very fast breaths, and these things called intercostal retractions, where the skin between the ribs gets sucked in, shows how hard they're working. You might also hear crackles in the lungs, like Velcro pulling apart. Doctors get suspicious when breathing suddenly gets much worse, oxygen levels drop and keep dropping despite support, often heading towards respiratory failure. And chest scans show these widespread shadows, infiltrates across both lungs, usually pops up within a few days of whatever triggered it. Now, these shadows can look like heart failure, but there's a classic clue for ARDS. The very bottom corners of the lungs often stay clear. It's subtle, but important.
Right, which leads to the question, how do you manage something so severe? The immediate goal is breathing support, non-invasive methods maybe, or full mechanical ventilation. And crucially, you have to treat whatever caused the ARDS in the first place. With ventilation, there are some really vital principles to protect those damaged lungs. First, there's PEEP, positive end expiratory pressure.
PEEP, right?
Yeah, it keeps those tiny air sacs, the alveoli, just slightly inflated, stops them collapsing completely with each breath out. Prevents ALEC trauma, helps oxygenation.
Okay.
Second, low tidal volume ventilation, LTVV. This is critical. It means using really small, gentle breaths from the ventilator. You don't want to overstretch and damage the fragile lung tissue. Volutrauma, they call it. The goal is low pressure inside the lungs. And this actually helps reduce damage to other organs too, not just the lungs.
Interesting.
And finally, of course, supplemental oxygen. Keeping levels stable, but not too high. For the really severe ARDS cases, sometimes putting the patient on their stomach-prone positioning can make a huge difference.
Lying face down.
Yeah, exactly. It helps open up collapsed parts of the lung, gets blood flow to better ventilated areas, can really boost oxygen levels.
Wow, okay. So that's the intense, acute emergency side. Let's shift gears now. Let's talk about something maybe more common, affects millions every night, but still really critical for long-term health. Sleep apnea. A lot of us know someone who snores, right? Maybe it's even us. But when does that snoring become, a real medical issue?
That's a really good question. What is sleep apnea really, and who gets it most? Our sources point to a few key risk factors. For men, a larger neck size, about 17 inches or more, has a strong link to obstructive sleep apnea, that's OSA.
17 inches, okay.
Yeah, obesity is another big one, BMI over 30.
Yeah.
It's also 2 to 3 times more common in men than women. And age plays a role. Tends to be more common in your 50s and 60s.
And when we say sleep apnea, there are different kinds, aren't there?
That's right. There's central sleep apnea. That's less common. It's where the brain just doesn't consistently send the signal to breathe during sleep. The effort decreases or stops.
Okay, a brain signal issue.
Yeah. Then there's obstructive sleep apnea, OSA, which is much more common. This one's about a physical blockage. The airway gets blocked during sleep. Could be throat muscles relaxing too much and collapsing. Could be large tonsils, maybe a deviated septum. Something physically obstructing the airflow.
So what are the symptoms? What should make someone think, maybe this is me?
Well, the classic signs are loud snoring, feeling unrested even after a full night's sleep leading to that chronic daytime sleepiness. And often, a bed partner might notice pauses in breathing or the person choking or gasping during sleep.
Ah, the observed apneas.
Exactly. And during an exam, a doctor might see signs like that large neck or a crowded throat area, maybe a small lower jaw micrognathia.
So diagnosis, how do they nail it down?
The gold standard is the in-lab sleep study, polysomnography.
Right, the overnight test.
Yeah, they hook you up to monitors brain waves, breathing effort, heart rate, oxygen levels all night long. It's considered positive if you have, a certain number of breathing interruptions or shallow breaths per hour. Blood tests might sometimes show something called polycythemia, that's extra red blood cells the body makes because of the chronic low oxygen. And doctors often use questionnaires too, like the Epworth Sleepiness Scale to see how sleepy you feel day to day. And there's a screening tool called Stoppy Bang. It's an acronym.
Oh yeah, I've heard of that.
Yeah. Snoring, tiredness, observed apneas, high blood pressure, BMI over 35, age over 50, neck size, and gender. Gives a risk score.
Okay, so once someone gets that diagnosis, what happens next? What's the treatment?
Well, it often starts with lifestyle changes. Losing weight if needed, avoiding alcohol, maybe changing sleep position.
Makes sense.
But for most people with moderate to severe OSA, the main treatment is CPAP. Continuous positive airway pressure.
The mask device.
Exactly. It blows air gently through a mask, just enough pressure to keep the airway open while you sleep. It's really effective. If someone can't tolerate CPAP or it doesn't quite work, there are oral appliances, kind of like mouth guards that shift your jaw forward. Usually less effective for severe cases, though.
Oh.
And then there's surgery. A tracheostomy, making an opening directly into the windpipe, is like the definitive cure for really severe, life-threatening OSA. But it's a meager step. Other surgeries might reshape the nose or throat tissues.
It really highlights how our body's structure impacts function, doesn't it?
Mm.
And speaking of body structure, there's another condition that ties obesity and breathing problems together really closely. Let's talk about obesity hypoventilation syndrome, OHS, sometimes called Pickwickian syndrome. This is basically when someone who is obese doesn't breathe adequately even when they're awake, and there's no other explanation for it.
Mm-hmm.
It seems to be this mix of the brain's drive to breathe being kind of blunted, plus the sheer mechanical weight of obesity making it harder to expand the chest and lungs. And here's a really striking link. About 90%, 9 out of 10 patients with OHS also have obstructive sleep apnea.
Yeah, the overlap is huge.
So how does OHS actually show up? What are the signs?
Well, patients usually have symptoms from both the obesity and the sleep-disordered breathing. So you see shortness of breath, feeling really tired, excessive daytime sleepiness. Plus the snoring, the witnessed pauses and breathing at night, drops in oxygen during sleep, and just feeling generally sluggish during the day, often because carbon dioxide levels are chronically high in their blood. They're just not breathing it off effectively.
Okay, let's unpack the diagnosis then, especially since you said it's often about ruling other things out.
Right. The criteria are pretty specific. First, obviously, obesity, a BMI of 30 or more. Second, proof of hypoventilation. That means high carbon dioxide levels in the arterial blood, usually measured with an arterial blood gas test, and ABG, PaCO2, above 45 millimilli.
That's high CO2.
Third, there has to be evidence of sleep-disordered breathing, which, as we said, is usually OSA. And fourth, you have to rule out other conditions that could cause poor breathing.
So how do they test?
If there's high suspicion, say, someone's significantly obese and known to have bad sleep apnea, they'll likely go straight for that ABG test to check CO2. If suspicion is lower, maybe they'll check serum bicarbonate first. If that's high, it suggests the body's compensating for high CO2, makes OHS more likely, and then they do the ABG.
Okay.
And obviously, if sleep apnea isn't already diagnosed, a sleep study is essential.
So managing OHS, it sounds like it needs a few angles.
Absolutely. It's definitely multifaceted. It almost always starts with two things together. Immediate non-invasive positive airway pressure ventilation, or NPPV.
Like CPAP or BiPAP.
Exactly, like CPAP or BiPAP, often BiPAP because it helps more with blowing off CO2, and simultaneously major lifestyle changes focusing on weight loss. Those two are the cornerstones. They help improve oxygen, lower CO2, and improve the body's breathing drive.
And the sleep apnea part.
If severe OSA is there, you have to treat it aggressively. usually with CPAP or NPPV. Getting that under control significantly helps the daytime high CO2 and low oxygen in many OHS patients. It's also really important to find and treat any other conditions contributing, like maybe COPD or complications like pulmonary hypertension.
And heart strain.
Yeah. And patients absolutely must avoid things that suppress breathing. Alcohol, sedatives like opioids, barbiturates, benzodiazepines, they can make things much, much worse.
What if that first line stuff doesn't work?
Well, then things get more serious.
Yeah.
Options might include tracheostomy, maybe bariatric surgery for weight loss, sometimes weight loss medications, but these are higher risk and less ideal. And here's a really crucial warning from the sources. Just giving someone with OHS extra oxygen by itself can be dangerous.
How so?
It can actually blunt their already weak drive to breathe even further, making the carbon dioxide levels climb higher. So oxygen should really only be given alongside NPPV to make sure they're actually ventilating properly.
Wow, that's counterintuitive.
It is. And untreated OHS, it carries high risks, serious health problems, even death, mostly from cardiovascular issues like that pulmonary hypertension, right heart failure, and much higher risks if they need surgery for anything.
Okay, just briefly, before we wrap up, our sources mentioned a few other distinct abnormal breathing patterns, just as a glimpse into how complex this all is.
Yeah, it's a good reminder of how breathing patterns themselves can be diagnostic clues. There's Cheyne-Stokes respiration, that's this cycle. Breathing gets progressively deeper, then shallower, then stops for a bit, apnea, then starts again. Often linked to reduced blood flow to the brain, like in heart failure.
Okay, cyclic.
Then Biot's respiration, that's more irregular. Quick, shallow breaths, all about the same depth, but with regular periods of apnea in between, can indicate damage to the brainstem, the medulla, or sometimes opioid use.
Irregular pauses.
Right. And finally, Kussmaul's respiration. This one's different. It's deep, rapid, continuous breathing,
Yeah.
big breaths, no pause between breathing in and out.
Non-stop deep breaths.
Exactly. It's the body's desperate attempt to blow off excess acid, usually from metabolic acidosis, like in uncontrolled diabetes, trying hard to get rid of CO2.
So where does this leave us? We've covered a lot. From the acute crisis of ARDS, where the body attacks the lungs, to the chronic, often silent struggles of sleep apnea and OHS, seeing how inflammation, anatomy, weight, lifestyle, it all impacts our ability to just breathe. Hopefully you're leaving with a clearer picture of these complex conditions, how they connect, and what doctors look for. The whole system is amazing, really, until something throws it off balance.
Absolutely. And knowing this stuff is one thing, but understanding its implications is key. What strikes me is the body's resilience, how it tries to cope, but also how vital early recognition and the right management are for these conditions. So maybe the question to leave you with is this. Knowing how subtle some of these signs can be, how interconnected these breathing issues are, how might being more aware of the risks and symptoms change how we think about preventative health? Not just for ourselves, but maybe noticing something in a loved one. Could starting that conversation, make a real difference, something to consider.